Everyone. My name is Rebeka Stephen. I am an EMS physician and an emergency medicine physician in Buffalo, New York. I'm currently doing my EMS fellowship year, where my focus is on optimizing pre-hospital emergency care along with online medical control. I'm also an operational field response physician. So our response capabilities range anywhere from out-of-hospital cardiac arrests to mass casualty incidents, search and rescue, and air medical transport. One of the biggest motives in pursuing EMS fellowship I had for this year was to gain expertise in systems design and operations of EMS, because there is an urgent need for better EMS development in the global health realm. So that's what we will talk about today. In this lecture, we'll go over the basics of EMS in a global health context. The objectives for this lectures today are fairly simple. We'll discuss the two distinct philosophies in pre-hospital emergency care, the high income versus low middle income country models for 911, and the resources, the training, the infrastructure that is needed for EMS development. And finally, why understanding our local systems is so important to learn how to adapt systems for the international work that you pursue. So there are two systems of thinking when it comes to EMS. There are very distinct philosophies, but they have the same mission. It's to deliver pre-hospital emergency care appropriately in a timely manner. The Anglo-American model is the model where you bring the patient to the physician. It is a paramedic-led model. Load and go is the concept behind it, where you deliver key stabilizing interventions on scene and then you immediately transport to the emergency department. This sounds very familiar because this is what we do in the United States. There are other countries that follow the same systems, like Canada, UK, Australia, New Zealand. And this system is very easy to scale in larger cities and countries, especially in the context of physician shortage right now. In contrast, you have the Franco-Germanic model. So this is the system where you bring the physician to the patient. These teams are physician-led with an RN. You'll see anesthesiologists, internists, pediatricians, instead of the paramedics that you typically see here. They have a treat and transport system where the physician is able to triage and treat on scene, and sometimes they go straight to admissions, completely skipping the ED, or sometimes not even transporting these patients. Once they're treated on scene, they'll set up outpatient follow-up and go from there. You'll see systems like this in France, Germany, and Austria. It's a great system, and both of these systems have many differences that we'll continue to talk about. The big difference between these two systems is the overarching organization that they report to. In the Anglo-American system, it's a public safety organization. What this means is that the EMS is integrated with the fire and the police department. And the Franco-Germanic model is a public health organization, which the EMS is integrated into public health and social security infrastructure. Why is it important? It's the funding. So the money to support EMS systems come from different places in each of these models. In the Anglo-American model, it's a mix of insurance, billing, tax subsidies, in some cases private or municipal fire-based operations. In the Franco-Germanic model, it's a public health system in which is financed by the public health insurance systems, the social security system, and grants. If you mix these two models and who they report to, you definitely do risk the collapse of the system, because they when you need money for the upkeep, they can play hot potato in terms of not my problem. So most of the system kind of stay one way or the other when it comes to funding. Some other general differences between these two models are, in the Anglo-American system, you have a shorter scene time because stabilizing and moving fast is kind of the point. There's a heavy emphasis on time to definitive care, which is reaching the hospital. Versus the Franco-Germanic model will have a longer scene time because the physician on scene can provide some of those definitive care that is needed. The Anglo-American system is definitely less expensive pre-hospital wise, versus Franco-Germanic is more expensive. And that's because of the training and the upkeep that is needed for one system is more resources intensive than the other. The Anglo-American system is more scalable in larger cities because it is faster to train trained paramedics, and there are just generally more EMS personnel available to run the system compared to the physician-led teams in the Franco-Germanic model. The other big difference is the dispatch philosophy. So 100% of the call that comes to the Anglo-American model in EMS dispatch, EMS is dispatched to scene, and they either eventually go to the emergency department or they will do an against medical advice refusal. And about 65% of the calls in the EMS dispatch system in the Franco-Germanic model gets EMS dispatched to the scene. The reason for this is because there is a physician medical regulation at the dispatch level, meaning there's a physician available with dispatch to triage the calls, and they determine in the appropriate level of care, leading to higher or more targeted resource allocation. The other big difference is that the Anglo-American model has online medical control and protocols available where the paramedics can act independently in a lot of ways. So the reality is not black and white. It is no country focuses on a single system. It's a mix of both systems. One philosophy is not better than the other. And it's extremely tough to compare these two models because the philosophy and the goal is very different. In the world of EMS, you've probably heard of this. If you've seen one EMS system, you've seen one EMS system, meaning a system operates so differently from each other. So nowadays, what you'll see is a more tiered system. It's more precise. So they start with a BLS, basic life support crew, where they can come evaluate more lower acuity problems and low and go. And then you'll have your advanced level system where you have either an advanced EMT or a paramedic. They will come, stay and stabilize. They run cardiac arrests on scene. They can do needle decompression, thoracostomies, things like that. And then you have a field physician response system, which is what I do. So even in the United States, the system is not fully standardized. So all systems internationally even lean one direction with features of the other. So a tiered system is more so what we're moving towards. So let's say you want to design an EMS system in a brand new country. What resources do you need to set up and run the system? So first of all, you need the people, the human resources. So you need your EMTs, your paramedics, your dispatchers, and your physicians. But not just that, you need everybody that runs behind the scenes too. So you need your mechanics that will upkeep your fleet. You need the IT department, the HR department, and many more other resources like that. The second group of thing that you'll need is the infrastructure. So the equipment, not just the medical equipment like the monitors and the defibrillators. You also need the operational equipment like the radios and communication systems. You need your EPCR documentation systems. You also need medications, blood, the upkeep of it, the maintaining the expirations for it, and finally, the documentation, along with the devices, you'll also need a system to do it. Some people do the paper system, but a lot of the EMS crews have switched to an online EPCR system like ImageTrend or ESO. There's many different groups out there that does this. The next section is going to be education. So you need your initial education, you need your accreditation, and then you'll need your continuous medical education. Then you need your funding. We talked a lot more about this when we started the lecture, which were the public safety versus the public health system funding the system. And finally, you need oversight. At the basic level, this means protocols and established systems like that. Then you need your online medical control or on-scene medical control. You have your medical director, and then you have your quality improvement team that look at all of the charts and make sure that things are done properly and care is delivered properly to the public. So this is where you see most of your Franco-Germanic models. You have your Europe, Southwestern Europe area, North Central Europe, and then you go down to Latin America. So Brazil, Chile, Argentina, Uruguay, you'll see a lot of the Franco-Germanic models. And then you have your Anglo-American models, mostly in the United States, Canada, Australia, and in Asia. When you move towards Asia and the Middle East, you'll start to see a lot more of the hybrid system that is pretty strong. So in Asia, Japan has physicians for critical care units. China has hospital-based EMS physicians. In the Middle East, you'll see this in UAE, Saudi Arabia, and Israel. So funding matters in EMS when it comes to who can access the healthcare and who makes key decisions. So whoever gives up the money makes key decision. So this is something that you have to pay very close attention to when you're involved in establishing a system, because this can create disparities in access. So we'll go through a few different countries and the models that they pursue. Um, the first one is going to be Netherlands. Netherlands follow a very Franco-Germanic model. I have to give credit. This lecture part was I had some contribution from one of my colleagues, Garth Rivers, who was an acute care nurse practitioner in the Netherlands. So this system, you have, instead of physician, you have nurses at the dispatch level. So ambulance care can be dispatched with an urgency level of A1, meaning arrival of an ambulance in less than 15 minutes, A2, which is arrival less than 30 minutes, and then B, which is a planned ambulance care. Their education and oversight is mainly ambulance nurses. Once they get qualified and getting their RN and their ambulance nurse license, then they can work autonomously. So they use a national EMS protocol to work. A lot of the times, this means that they have specialized education and they also do a 2-year master's in nursing care. So Garth is an acute care nurse practitioner that practices in such way and in the Netherlands. Their funding is public health insurance. So the system is based on independent or regional ambulance services. It's not hospital based. It's not public safety owned. So that's where they get their funding from. And this is one of the systems that you famously see in a lot of the articles and news articles where they run ECPRs pre-hospitally. They cannulate people to go on ECMO. So next up is going to be your Anglo-American model, which the best example that we have is the United States. This is the system that I work in. So I can talk about a little bit more to my experience when it comes to this. So we do have both ground operations and flight operations. We have 911 system. It is a public safety base. So we are integrated with the fire, police, and EMS dispatch system. They're all grouped together. Once they get a 911 call, it's pretty much they click a button where they go to either police, fire, or EMS. We have a paramedic-based system. It's a 2-person crew. So you have your EMR, emergency medical responder, then your basic life support crew, advanced life support crew, paramedics, and then a physician response. It's a very tiered system. The education is about 1,800 hours or so. And the funding comes from local municipal property taxes or private funding, like from the insurance. There are a significant amount of regulations that happen in EMS, and that is done by the National Highway Traffic Safety Association, or called NHTSA. And they set the EMS system standards and recommendations and data collection for a lot of these regulations and practices are done by NEMSIS, or the National EMS Information System, which is where a lot of our research will come from and improvement of the system comes from. Oversight, we have protocols that are established. You have online medical direction or a physician that goes on call to scene. And we have quality improvement system done by the QI medics or the medical director. So what this means is that we look at 100% of intubations, cardiac arrests. They get reviewed to ensure that there aren't things that are being missed, and if there needs to be more training or changes made to the system to improve care. A lot of the field physicians in the EMS world is EMS fellowship trained after emergency medicine residency. This is an actively changing field, however. So this is a very new field where it's only been alive for about 15, 20 years or so. Next, we'll talk about a hybrid system. So the next up is Japan. And this lecture slide is courtesy to Ryu Kimura, who is a paramedic and who is getting his master, or currently a master of emergency medicine in Japan, getting his PhD. They have a system of 119. It's a hybrid model. So it's established in 1991, fairly new. And it is a fire department based system. but with public funding. It's a free ambulance transport system. This is where you start to see that hybrid model come into play, where they have a public health funding, but it's a public safety-based system. So, like paramedics in the United States, they have what's called an ELST, it's called emergency life-saving technicians. They have a significant amount of education, which is about 5 years or 2,000 hours of experience, or there's a PhD course that's 3 years and or 1 to 2 years master's degree. The interesting part about this is that they still have a very limited scope of practice. It's being nationally debated on the procedures that they can perform, but right now, the main procedures are really IV with acetonic fluids, epinephrine for allergies. They can provide dextrose and then advanced airways like supraglottic airways or AT tubes placements. They do have a fair amount of mobile ICUs, which is physician staff that can get dispatched from the hospital or on staff at EMS. And again, with that hybrid-based system, they have protocols as well as online medical control available. Next system that I want to talk about is the Middle East. Again, it's a hybrid system in Saudi Arabia. So Saudi Arabia system is government funded by the Saudi Red Crescent Authority. It's a high income country, but it has a heavy lean towards the Franco-Germanic model. So this is a physician-led dispatch with several field physicians. It's a free 24/7, and the number is 997. They have a hybrid model, and the education is about 3 years or so. One of the things that I want to point out here is that we need to keep the cultural context when it comes to global health in EMS in so many different ways. And one way this plays out in Saudi Arabia is the education. There's only 3.46% of the paramedics are female paramedics. And in the cultural norm of Saudi, female patients typically will need a female clinician. So this does create a significant amount of disparity in what they can provide on scene. The oversight typically is the field response physicians who have a single authority or regulatory body, which what that means is that they can take an idea, it's very quick to implement evidence-based practice. And they've been doing a lot of good work in the country right now. But they have a pretty significant difficulty in data collection. So that leads to difficulty in research, tracking progress, and improving the system. One of the very unique perspectives Saudi brings to the international EMS world is that they host Hajj, which is the single largest mass gathering event on the planet, bringing about 2 to 3 million people yearly to the same spot. So these are some of the field vehicles they have available there to do field responses in the desert and things like that. And again, thanks to this lecture, slide was prepared with help from the medical director of Riyadh, Dr. Ahmed. And last but not the least, I would be doing a huge disservice to the EMS world to not talk about Vietnam. Vietnam played such a crucial role in the development of pre-hospital care during their toughest period of the wartime. I recently had the privilege of speaking there for their EM Critical Care Conference this past year. Very interesting system that they have. Again, this is also a hybrid model in a middle income country. Most of the modern EMS practices have roots in the Vietnam War medical rescues. So their system is quadruple 9, which is based off of Ho Chi Minh City. One of the interesting things that they have contributed is into the dispatch system. In the US, we use something called medical priority dispatch system. They took that idea and created something called international academies for emergency dispatch. This has now become an internationally accredited dispatch system that are being adopted by other countries too. They have a physician and a nurse team, but a private corporate funding, again, highlighting this hybrid model that is starting to cross over in many different countries. But their growth is rapid and amazing in the world of emergency medicine and pre-hospital care. One of the things that they did to train their paramedics is they noticed that the paramedics get, or not, the field response physicians and nurses, they kind of get stopped by the drama of the scene. So they used theater. They send people to learn what theater is, to learn the drama of the scene and track the progress in how much better the care was on scene after this training. So that was pretty interesting use of other methods that we don't typically think of, very innovative. Can't go into too much details on low income countries because we have very little information on this. So this is the 2026 list of low income countries in the world. EMS systems are very unpredictable, fragmented because of limited infrastructure, poor funding, or lack of formal education and national guidelines here. The largest burden for low income countries when it comes to pre-hospital care is traumatic injuries and communicable disease, which this is something that can significantly be changed by improving pre-hospital medical care. So in my opinion, this is sort of the best focus for the maximum impact at this point in time. So we hear this all the time. Global health is local health. It is so much more it's significantly emphasized when it comes to EMS because the best approach to doing EMS in the international realm is education and systems building. The only way you're able to do that is by knowing your local EMS systems, because then you can bring value into this world. But knowing your own system of what works and what's not working, you can provide valuable information to help the system in wherever your field work is. There's a lot of economic and cultural integration that'll need to happen into that system. And finally, the goal is systems designs and implementation with a plan to set things in motion, and then you support it because self-sufficiency should be the key when it comes to international collaborative work for it to be sustainable long term, which is what we all want. So I want to leave you with this. When you go into your international work or your global health work, think about what value you're bringing to the system. Merely having an interest in it, it's great to have a good interest and a passion for it, but going into it with an expertise, with things that you can offer to improve the system is going to be really, really important. So there's a couple of discussion questions that'll be posted later. And those questions, so the first one is going to be, in what ways do the Anglo-American model versus the Franco-German model, EMS model, succeed or fall short in delivering pre-hospital care? The other question is going to be, what value or expertise are you bringing to global health? Think about this because then you can think about the next steps that you can take to develop these skills if you don't already have them or if you feel like you're lacking in certain areas. And that way you can contribute meaningfully to global health. Thanks for listening in today. Email me if you have any questions at all. My email address is on the first lecture slide. It's rebekast@buffalo.edu. I'm always happy to chat about EMS and global health, and good luck.